Right, I think we're going to get started. I suspect people will be logging in along the way because we had um, a number of participants who signed up. My name is Amy Verstappen. I'm the president of the Global Alliance for Rheumatic and Congenital Hearts, and we're extremely excited to be presenting today's webinar in honor of World Heart Day. The title of today's presentation is Advocating from the Heart. And what we want to highlight today is specifically the power of patient family organizations and patient family leaders to really make significant changes in government policy in their country and also globally. So we're very honored to have here today. We have 3 speakers here and another one should be coming shortly. Maya Olson, who is the Director of Advocacy at the NCDI Poverty Network. We have Anu Kathmandu, and Anu, did I say that right? Yes, good. Who's a Voices of NCDI Poverty Advocacy Fellow and also a member of Global Arch. And we have Anna Marie Sarnin, who is the co-founder and CEO of the Newborn Foundation. We're going to start out with each panelist giving a brief presentation about the advocacy efforts that their organization has done. And then hopefully we'll move on to a table discussion where you will be able to ask your questions, but I'm going to invite Maya to begin.
Thank you, Amy. As Amy mentioned, I am the advocacy director of the NCDI Poverty Network, which I will put my slides up because my first one talks a little bit about who we are, and does that show up for everyone?
Perfect.
Awesome. So the NCDI Poverty Network is a group of technical policy advocacy partners that are supporting countries to reduce the death and suffering of the poorest people in the world who live with severe chronic diseases like congenital heart disease and rheumatic heart disease. It is comprised by a number of national groups called National NCDI Poverty Commissions, which are groups of advocates, implementers, Ministry of Health officials, policymakers, technical, scientific, academic folks in each country. And then there's been lots of global and regional organizations. I work for Partners in Health, which is an NGO that works in a number of countries in Africa and Haiti. And we've done a lot of NCD clinical care over the years. And so I'm going to talk a little bit about one of our big advocacy wins, which was really inspired by some of the work that PIH has been providing patients, particularly across the African continent, that's really transformed the lives of people living with severe NCDs like RHD and congenital heart disease. I am actually going to cheat a little bit and talk about 2 advocacy wins because they really kind of pair together very nicely, and we learned so much from some of the efforts that the World Heart Federation and REACH in particular moved forward a couple of years ago with the World Health Assembly resolution on rheumatic heart disease and rheumatic fever, and that has since inspired some work that we've led a little bit more on an integrated strategy across NCDs. So in 2018, and this was kind of years in the making, as it always is, New Zealand as the lead co-sponsor at the country level, and really strong efforts led by partners and colleagues across the heart community, but particularly World Heart Federation at the time, successfully introduced and passed a resolution on rheumatic heart disease and rheumatic fever in Geneva during the World Health Assembly. The goals of the strategy was a coordinated global response around rheumatic fever and rheumatic heart disease, really addressing gaps for the poorest countries at the time, and still in many ways, NCD policy globally has really focused on metabolic heart disease and risk factors, modifiable risk factors like tobacco, alcohol, obesity-related factors, lack of exercise, all very important, all very relevant in certain settings, but it really misses kids and young adults who are getting these diseases, which often disproportionately impacts lower income countries or more poorer, more rural populations. And so really wanted to sort of address that at a global level through something like this, and put people living with RHD at the center of the NCD prevention and control agenda. World Heart Federation had been moving this forward. We jumped in and helped connect some of the countries we work with into the efforts, and we were really excited to be a part of it. But they also really gave us a playbook of how to advocate and advance some of the integrated policies we were working on across NCDs. So what we have helped WHO Afro pass recently, as in a month ago, August 2022, was a regional strategy for the PEN Plus model, which is an integrated strategy for outpatient care of severe chronic NCDs across the board, including rheumatic and congenital heart disease, type 1 diabetes, sickle cell disease, severe asthma, epilepsy, kind of the list goes on. And through sort of an integrated outpatient care model, the idea is that anyone in any region, no matter how rural you might be, can go to your district hospital, and there will be nurses who are trained and able to provide that intermediate level care, which has been often very, very missing, especially in lowest income countries, and refer up to things like surgery and work with the community level care. But there was this missing gap in district hospital. And so again, really focused on addressing gaps for the poorest countries and building a movement and putting people living with severe NCDs across disease-specific communities at the center of the agenda for the region. In terms of some of the tactics and strategies we've used, I think we're all here because we're sort of united as people living with NCDs or people affected by these conditions. I'm a cancer survivor, so I'm really excited to hear from Anna Marie and Anu and others who are more personally impacted by heart disease, but we learn so much from each other as people living with severe NCDs. And so kind of first and foremost was advocacy, really putting the stories and experiences of people living with rheumatic and congenital heart disease in front of audiences, in front of policymakers, and building a community amongst ourselves. And so some of the stuff we've done specifically with advocates, I'll let Anu kind of shine herself through this, but we've worked with advocates on writing pieces for articles and stuff online, speaking in events. There are advocates living with RHD speaking at the World Health Assembly, at the UN General Assembly. Video has been a really powerful format to be able to share stories. Wesley, who's in the video, the NCD Alliance video at the bottom, had a chance to be in a global consultation with other people living with NCDs and helped develop, that group of advocates helped develop the advocacy agenda for people living with NCDs with the NCD Alliance. So there's all sorts of ways that we as people affected by these conditions can help change the narrative, move people, move policymakers to look at these issues differently. In terms of these strategies themselves, it was a long road for both of them. I don't know when the World Heart Federation started with the resolution. It took us about 6 years for the PEN Plus regional strategy to move through all the processes. And they can be kind of slogs and slow and technical and frustrating. But one of the strongest tactics that can really unlock some of this progress moving forward is working directly with some of the policy bodies like WHO. And so we have our program director, Jean Bookman, who's a cardiologist, sitting down with at the time, he was the director of NCDs for WHO Afro, and kind of really working technically through some of the process, talking directly to ministries of health. There's a meeting photo from the 2018 WHO AFRA meeting, which was one of the first times we sat in front of the member states and really talked through the potential strategy for Pen Plus. The photo in the middle is REACH and a palliative care group in Kenya, and our NCD director, our NCD lead, who's worked in Rwanda, the Nigerian ministry, kind of all sitting there getting into the weeds of the policy at a consultation that was held in Rwanda. And then really providing guidelines and tools for other civil society advocates to bring their countries and their delegations into the work. And so speaking of taking the playbook, the 2018 sort of campaign toolkit that the World Heart Federation did, that was really clear. And here's how you talk to your ministry. Here's the advocacy messages to bring to them. This is what we want to see in the member state discussions. Advocate away. We did a very similar thing with the 10 plus resolution, and it really helped bring super strong discussion forward from countries like Uganda, where the Uganda National Commission worked directly with the ministry, and the minister of Uganda is giving one of the sort of stand-up statements from the meetings that just happened with the ministries of health to pass the resolution about a month ago. We as civil society also have a voice in these sorts of meetings. The big photo in the middle is Alistair White. Ali was giving the statement on behalf of the World Heart Federation. The NCD Alliance gave a statement that we worked with them on in the WHO Afro regional consultations. It's a really good chance to kind of get our voices out in those discussions directly with ministers of health and the official delegations. I included the photo on the left, which speaking to some of the challenges of advocacy, when we went into the meetings in Geneva, there was, I think, 5 organizations, us, World Heart Federation, NCD Alliance, who were all speaking on behalf of civil society. We had been working for 2 or 3 weeks to really refine our statements, working with all of our doctors and technical leads, had everything word perfect. Me and Ali show up in the assembly to give the statement, and they said, you don't have 2 minutes anymore, you have 1 minute, say everything you need to say in half the time. And the 2 of us had to sit together and took the WHF statement and the PIH statement and just cut everything. And you have to kind of adapt as you go, and things like that can throw you for a loop. But if you're really clear on your advocacy messages, right, you can move things forward. So I think what's next for us, continuing forward, promoting what we've been working on in equitable access to severe NCD care. We've got upcoming events. The next big one for us is on November 10th. Many countries across the African continent, as well as a few countries in South Asia, like Nepal, are going to be initiating new programs in Pen Plus. And so we're really looking forward to working as a consortium to make sure that those are successful and provide that case in point that this care is important and it works. And then doing what we're doing here, building a movement among people living with NCDs. We have some platforms that we do that, like the Voices Fellowship, but we're really excited to be working in close collaboration with organizations like Global Arch and the RHD and CHD communities. And then financing is the big thing that everyone needs to figure out how to make happen. And so we're pursuing that in different ways, and that's a big part of our call to action. So hopefully I didn't take up too much time. Looking forward to hearing from others and the discussion. And I will stop sharing.
Thank you so much, Maya. Anu, you're next.
Thank you, Amy, and thank you, Maya, for sharing. I think I will turn off my video to save the bandwidth so that there will be no internet problem. Just to share my screen. Okay.
Okay, perfect. We can see it beautifully, Anu. You just might want to, there we go.
Okay, so I'll start my presentation and actually sharing about my experiences and regarding the lived experience of rheumatic heart disease and advocating for the people living with congenital heart disease, rheumatic heart disease, and other NCDs. So hello everyone, greetings from Nepal and happy World Heart Day. My name is Anu Kathmandu, and I'm so happy to be a part of this webinar co-hosted by my family, Global Arch, and the NCDI Poverty Network. Today, I'll be sharing about a few things on how and why people living with NCD, or especially RSD and congenital heart disease, we have the voice and we can bring positive impact for our health. To just give my quick introduction shortly, with my academic qualifications, I am a public health professional and a global student at Thammasat University. But I feel happy to also introduce myself as NCD advocate due to my medical history and conditions. It has been over 20 years since I was diagnosed with rheumatic heart disease. Like many of us here, I have been under medication enduring a life-threatening health conditions and 2 open heart surgeries for my mitral valve replacement. At the age of 11, I was first diagnosed with rheumatic heart disease, and I went through my first surgery in that age. And in 2016, I had my second surgery, and all this has impacted me and my family on physical, emotional, mental, and financial level. The challenges were different, and those challenges those challenges and experience slowly paved the way to getting involved in this NCD advocacy. And to highlight my experiences is not just a thing that doctors or care providers will treat in the hospital, but beyond. And we have responsibilities, and the resources I had in this journey mainly were my lived experiences. And currently, as the Voices of NCDI Poverty Advocacy Fellow, I am with the NCDI Poverty Network. I represent rheumatic heart disease community in this fellowship. And Maya has already shared about what NCDI Poverty Network is, so I won't again go through this. But yes, in this network, we have the Nepal NCDI Poverty Commission. It is one of the national poverty commission in the network, and the Nepal NCDI Poverty Commission is housed in Kathmandu Institute of Child Health Kioch. So to briefly give the introduction about this, the Nepal NCDI Poverty Commission conducts analysis to assess the national NCDI burden among the poorest, and to identify and prioritize policies, interventions, and integrated delivery platforms that would effectively address as well as reduce the burden. And Kathmandu Institute of Child Health Kioch, it is a children's hospital network aiming to establish a multi-speciality hospital in all provinces of Nepal, which will provide affordable, accessible, and quality care to the children in need. And it is also an implementing partner for the PIN Plus partnership project that again Maya has already shared before. So as the Voices Fellow, I work with this fellowship team in the NCDI advocacy on global level, and also in financing and promotion of PIN Plus and PIN Plus partnership from basic perspective, and promotion of meaningful involvement of people living with experiences to redefine NCD narratives are some of the examples that I, along with other 3 Voices Fellow, we do in this fellowship program. And we also represent in the steering committee of the NCDI Poverty Network, where decisions are made for the people living with NCDs. So we find this opportunity a really great platform to share our voices and experiences and our needs. And for the national and local level advocacy in Nepal, I work with the Nepal NCDI Poverty Commission and the KIOCH team. So to share about the individual advocacy project that I am currently doing in this fellowship is the Connecting Hearts to End Heartbreaking, which is, in short form is Chair Hearts. It is my project that is supported by my fellowship team and the NCDI National Commission, as well as the organization that I mentioned before. The overall change that I expect from this project is to enhance the health-related quality of life of people living with rheumatic heart disease and congenital heart disease, with an increased solidarity among us through health literacy and and also decreased self and public stigma. I think this would be a good spot to start my advocacy journey. And from this project, I am the expected outcomes from this project is a formal group of people living with congenital heart disease and rheumatic heart disease in Nepal is formed to spotlight our challenges and needs. And also this group will do activities in awareness or prevention and also self-support in this. And also from within this group, I aim to achieve or collect the data and documents of lived experiences so that we can use it in the policy advocacy. So why I did this is because we share common values and we hope for a betterment of our own and others' health, and we have the same expectations, and we know the problems of living with this condition, and we are also a part of it. So in order to advocate on this, I started this advocacy project. And we also know there are challenges to access to care and treatment and commitment to treatment or medications or care. So I believe the existing challenges to commitments to care can be solved in consultation with people like us. And likewise, the skilled people such as medical care providers, researchers, they all go to school to achieve or learn the skills that they need to do in order to treat us. But we as a patient, we do not have such facility, or we do not have those opportunities where we can learn to cope with this our condition. We struggle a lot. We live or we learn from our experiences till the last day of our life. So I think these are the important factors that drive me in this action. And from patient perspective or from patient advocacy, I think you and I can make difference here. Talking about my implementation strategies for this chair huts, one is the formation of group of people living with condition in Nepal. So this is in this screen, you can see the Facebook page of the group of chair huts. And I have recently created it so that we can invite many people who are living with this condition come into one platform, and we can share and support each other. And also I hope that this group will increase health literacy on our condition and support in empowering each other. Another strategy in my project is promotion of painless partnership and other NCD interventions like the WHO package of essential non-communicable disease interventions, to spotlight on the interventions that are cost-effective, affordable, and acceptable, because these are really very important in the countries like Nepal or other lower middle income countries. And in Nepal, PAIN Plus implementation, in this PAIN Plus implementation, I have also created a concept to involve people living with rheumatic heart disease, congenital heart disease, and other NCDs also. And another strategy that I took was is to collect, publish, and use the book of case stories of people living with rheumatic heart disease and congenital heart disease for policy advocacy. I think this will bring attention to all the relevant stakeholders, and other plans or strategies include doing the advocacy research and assessing the interventions that assist livelihoods of vulnerable groups and people living with NCDs, because poverty and NCDs are correlated. We all know this. So I assume all these strategies will help to establish solidarity, increase health literacy, and empowering each other, and increase quality of life, and also contribute in policy advocacy, thus marching to achieve the goal of this Chair Heart project. To share briefly about the achievements so far and way forward, I've listed a few points, but there are so many other things that I could not. But to share, so I have created the Facebook group for the Chair Hearts project. And before that, the main achievement that I'd like to highlight or share is that I accepted my condition not as the fact that will make me sad, that will make me feel weak, but I accepted it as my resource to speak for myself and other people who are living with this condition. And yeah, and to share other achievements, yes, at the national level, I now work closely with my surgeon to co-plan and implement the advocacy activities as a part of my Voices Fellowship. And likewise, I have created, since I've created the group, I am also promoting it in every platforms wherever possible, so that they can also share about this and recommend others to join and learn and support each other. I have come up with other strategies also, but yes, I plan to work on it in the coming days. The concept of involving patients and their providers in the PAIN Plus partnership project has also been approved, and it will be soon implemented in Nepal. And also we will be collaborating with the Nepal NCD Alliance with the support of WHO to bring together people living with NCDs and lead this initiation. And also at the global level, we fellows have highlighted that people who are living with NCDs are becoming more empowered. So all the relevant stakeholders have to prepare for us. Also in the recently organized events like World Heart Summit and other side events around the World Health Assembly, I spoke for our needs and our views. I also expressed our demands to increase commitment and investment in preventing rheumatic heart disease, including congenital heart disease and also securing a qualitative treatment for us, and also investing in preventions. And recently, my lived experiences have been featured in the WHO film series on Nothing for Us Without Us. And I'm hopeful that this will also help me to achieve the goals that I have taken in this NCD advocacy. These are the glimpse of few achievements that I just shared. So here's the surgeon that I work with, and this picture is the national conference where I I got chance to share about what people living with NCDs and people living with congenital heart disease and rheumatic heart disease go through, and what we need in this journey. So yeah, these are the pictures. And yes, thank you again for this. And I'm looking forward to work with you all, because this advocacy journey is really a challenging as well as a real need for us. If I have not got chance to be involved in this fellowship, I wouldn't be able to have network or meet people who are working in this sector. And if I had to solely start my advocacy journey, it would have been really challenged. But with the support of each other in this journey, I think we can do many more. So thank you once again.
Thank you so much, Anu, for your inspiring story. We're next going to go to Anna Marie Sarnin. And Anna Marie, I'm very mindful that this is a very different story, in part because we've talked a lot about people living with the disease, but you're here representing a very important other population that speaks out, which is the people whose children and family members are living out with the disease. And of course, in poorer countries, we know that there are unfortunately very few people living with congenital heart disease. So, you know, your voices, these voices are really important. So if you could go away, and I want to just note in terms of time, we're at 9:30. So if you can keep it to 10 minutes, that would be great, or a little shorter. So Anna Marie, take it away.
Sure. Thanks so much. And yeah, thanks for recognizing sort of the nuance of like parental advocacy or advocacy on behalf of those who either don't have a voice or haven't developed their voice yet. It's a different little space to play in. I'm also someone who's had a cancer survivor, and I have a great appreciation for these perspectives. And honestly, I've just learned so much in this short 30 minutes we've been together from the two of you. So thank you for this opportunity. I'm going to go ahead and pull my screen up. You guys can let me know if you can see it all right. Hopefully you don't have to look at my ridiculously messy desktop in the process. Are you able to see?
Yes, we're all good.
Perfect.
That's a pretty darn cute picture.
Yeah, this is one of our babies that we picked up in early newborn screening internationally when we were implementing it. So I'm trying to think of the most efficient way to fill in. So there's a little bit of like, I think we're going to touch on the real foundational work of even being able to approach something from a policy standpoint. And this was, again, my experience. It's where I came from in my journey. It's not the way all NGOs work. It's not the way every advocacy organization works. We're less patient and family facing than a lot of other organizations. And that's it's really great, actually, because the reason we chose that is because congenital heart disease, at least in the United States, where we had our start, has an amazing network of advocates. And it was like, we just need to tap in to that network and those people already, and then maybe lean into our strengths, which are on the research, implementation, and policy side of things. So this is where, you know, we started as a family. This is my baby Eve, and she was born after an uneventful pregnancy, and as uneventful as pregnancies can be, I suppose, when you're, you know, chasing after your other kids. But she was diagnosed just prior to us leaving the hospital at 3 days old with heart failure. I don't say congenital heart disease because she wasn't diagnosed with congenital heart disease at that point. She was, all we knew and all the doctors would say and all the ultrasound would show is that she was in heart failure. It took us another 3 days plus another 4 on top of that to recognize that she had a severe mitral valve defect that was causing all of the other organ failure, including the enlarged heart and other organs being pushed down into the stomach cavity. And then that she was having SVT. At first, it was a little sporadic, and then it became kind of like a round the clock thing that we had to control her crazy tachycardia, which was actually exacerbating the birth defect part of her congenital heart disease. And I share that with you because when she was diagnosed, when there was a cardiologist standing in my doorway telling me we needed to immediately emergency transport our baby to a tertiary care center or a children's hospital, she looked perfectly healthy. And that is really why, I had to, really dig in. This was probably even while we were waiting for her congenital heart surgery, into the statistics around congenital heart disease. I happened to already serve on the steering committee for Children's Heart Link at that time, which is another Minnesota-based NGO that works on everything from diagnosis to connecting care to setting up surgical sites, centers of excellence to treat children with congenital and pediatric heart diseases. And so I knew just enough to be dangerous, but really just didn't have an appreciation for how many children in our country were diagnosed with CHD each year, how they were diagnosed, and if there were situations like mine where I had a child that didn't look sick, that was incredibly sick. And so this was sort of the platform, is understanding that 1 out of every 3 newborns in our country ran the risk of leaving the newborn nursery undiagnosed. And then 1 of 6 of those were diagnosed by the morgue. And so it was very difficult for me. Like, we're in a high resource setting. How could this be happening? What could be done? So once we had this sort of statistics sort of figured out, including not just the burden of disease in our country, but what this results in, right? Like, even with the tremendous advances in being able to treat kids with CHD, it still accounts for a high number of deaths in the, sorry about the dogs. Hey, dogs. Around the world, from partly from late diagnosis, partly from misdiagnosis, partly from poor access to treatment. I'm literally throwing things at my dogs to get them to stop because I'm alone in my house right now. So our pathway was to develop a pilot with our daughter's hospital, and then 5 other hospitals in the region, along with the State Department of Health, to demonstrate what we were seeing in early data in Europe around the use of pulse oximetry to flag a potential heart problem. So a pulse oximeter tells us a baby's hypoxic. It doesn't tell us why they're hypoxic, but it gives us a really good pathway to actually diagnosing that child before they leave a setting, and ultimately go down that road of late detection and potentially a poorer outcome. I share this like timeline for you. You can see it only goes to 2012. It started just 2 months after my daughter's heart surgeries as a baby. But you can see what I added was that little box at the top that says 2018 Idaho implements screening, just to give you an appreciation for how long it really took for every state in the United States to formally implement universal screening. Almost all the babies were being done even without that requirement. But in 2018, Idaho finally passed its own mandate through public health that every baby in Idaho be screened. And this, of course, as Amy pointed out earlier, it takes a village, right? There were many, many other parents that advocated for this to become not just standard of care, but required, meaning there's a public health mechanism to make sure every child gets screened. And I can tell you a good number of the people in this photo, and of which many, many more are not pictured or listed, but a good number of them advocated after they lost their baby. And they are the real heroes of the story here, because they pulled themselves up by their bootstraps. They didn't have any policy or lobbying background, maybe some of the tools that I already had in my toolkit to pursue this. And they just did an incredible job. They just didn't want one single other parent or child to die needlessly because of a later misdiagnosis. So this data sort of idea here, it was about not just publishing that paper or getting that early data that we could take to the Federal Advisory Committee on Heritable Disorders in Newborns and Children to get congenital heart disease added to the screening panel. It was about educating care providers. And that included pediatric cardiologists, included frontline pediatricians, included nurses. And all of them had a little bit different take on like, well, the workflow, and well, it could be something that causes a lot of unnecessary extra tests. There were a lot of things that we had to work through from a scientific medical data standpoint to put us in a position to achieve public health implementation. And so without that foundation, which is how the Newborn Foundation works in every other country now that we've worked in, is setting up, similar to how we did it in the United States, pilot projects with hospitals that deliver babies and hospitals that take care of sick babies once they're diagnosed. We needed both of those communities on the clinical side, and then always with the Ministry of Health at the local, provincial, or national level. We don't need them to fund it. We don't need them to necessarily be engaged on a day-to-day basis, but we need the level of awareness that we're doing this project. We're going to provide you with the data to show what this means long-term for investments so that you can sustainably keep screening children and make sure that they receive the required follow-up care. And this was just a couple of the other pieces that validate the continued expansion of early diagnostic and treatment programs for congenital heart disease. If you don't have sort of the data to show it's not just effective in finding kids sooner, saving lives, but also that there are some real social and economic gains by being able to use a simple tool to screen, we won't be able to sort of continue to build on those early wins. So sort of those cost effectiveness studies continue to happen. A couple of them have been very impactful here just in the United States, but now in most of the countries we work in, this is sort of a commitment that we make together with the public health agencies to measure and make sure that they know how they can continue to improve those programs. I include this slide in a lot of my talks for a long time now, so I hope it's not getting too dated, but the idea of what can be done to reduce the mortality and morbidity associated with childhood heart diseases is a critical sustainable development goal, and it's a critical agenda item for both WHO and the UN Every Woman, Every Child initiative. And so again, from a data standpoint, it's really nice to be able to provide as a community them more and more information on how these programs are impacting and improving outcomes for kids. I sort of land on this map. We try to update it as often as we can with our colleagues at Children's National. There's a group of about 5 or 6 of us that sort of input data into this global map. There's 3 like orange lines on there because those show countries that we haven't flipped the color. They have actually implemented universal screening programs as of the last 12 months. Mexico is a very big deal. The Mexican Commission and the Health Department adopted universal screening. So now we're in that critical implementation and rollout phase. Mongolia has universal screening, as does the Philippines. I think that's it. Thank you for letting me share. And I am always available. I don't know if I put my actual email in here, but it's very easy. It's just annamarie@newbornfoundation.org if anyone ever wants some of the tools or to just talk shop and how you might be able to advocate for your own priorities anywhere in the world. It's been a great joy and blessing to do this work.
Thank you, Anna Marie, for that excellent presentation. And if you could stop sharing so we could get back to, there we go. That's great. Unfortunately, I don't think Tendai Moro is going to be able to join us today. She's having a lot of technical problems, So we've got 10 minutes left. So I wanted to get all of your thoughts on a number of topics. I will say that I learned a lot from each of your talks, and I really found it very inspiring. I just want to summarize some things that popped out to me before we get started, just to highlight where I see real messages that are coming from all of your comments. The first is that this essential interface that support groups have with advocacy in so many ways. So we think of that as really separate, but what I hear is, first of all, you need to empower people to speak up. They can be advocates, but only if they're not ashamed. You can gather those stories, and this can be fed. And there was a lot of talk about advisory committees in governments. This is super important. We're always saying to people at Global Arch, sending people the link, saying get on World Health Organization, your local government, if they have any advisory committees, get on it, get your voice there. You can do that also in lobbying meetings. I know, Anna Marie, because I remember when you were doing this, really, you're just telling your story. And that's how powerful that is to lawmakers. And that's certainly my experience in the US space as well. So that's sort of the power of the stories. Then a lot of what I heard coming out is how do you talk to government? And again, the economic impact and the numbers, that what they want to hear is those things, because you get in by your story, but then, those kinds of issues. And the other I'm hearing a lot is perseverance. How long this takes. So I wanted to start out with some specific questions before we take questions from the audience. So I'll just do one here. So in terms of your journey, I want to hear what has been the hardest thing about you advocating, like what's been the biggest challenge and how have you overcome it so far? So I'll start. Who wants to start? Maya, you want to start?
Sure. I think there's a personal answer, and then there's the sort of professional answer. Kind of the professional answer to that is we are pushing up against a lot of dogma when it comes to NCDs in settings of poverty. The kind of global frameworks for NCDs have been really built around other issues. It's been not the sort of conditions that we see here that are uniting this group, rheumatic and congenital heart disease, some of the other endemic conditions, infectious related NCDs, conditions that, try as hard as you might, you're in a setting where you can't control the prevention options that you might have to not get NCDs. You get an NCD, you're living in a country where you don't have access to care. And kind of global policy just doesn't really care. You're lost, it's fine. It's, you have those opportunities in other countries, but, and so that, it's been, frustrating to push against. You can't prevent your way out of the NCD crisis. You need to have treatment. We're missing this sort of segment of the very lowest income countries, and that's not okay. And there's a moral argument to that. There's an economic argument to that. There's a burden of disease argument, like those sorts of things. It's been hard because it feels so obvious that we need to be building our global policy and systems and financing around to take a Paul Farmer, preferential option to the poorest, the most marginalized, the hardest to reach. And it feels just the obvious moral argument, but it's a really tough one to make in terms of the way policymakers are thinking about, low-hanging fruit or, the most cost-effective opportunities, when sometimes, preventing kids and young adults from dying actually has more economic returns than some of the broader population-based measures that are really important that we've been mostly focused on. And so that, I think, is just it just requires continuing to push and push against this dogma. I think for me as an advocate living with an NCD, obviously I am from a wealthier country, and so there's places where I don't feel like it's my voice that should be the one out there. But it kind of can be challenging of when do you lead with vulnerability versus hide behind the organization that you sit in. PIH and Harvard and NCD Power Network have such cachet that sometimes it's easier to just be the advocacy director and not, lead with my personal story. But the sort of relationships and community and the work can be really hard, but you are inspired to continue to do it because you're inspired by your peers and getting to know Anu and getting to work with all of the people that were in the photos that I shared. I have gotten to be close with other people living with because I also kind of put my story out there and made that a part of my work. And so, yeah, I'll go with those two. Oh, I think you're on mute.
Anna Marie, would you like to add any comments to that? What is hard for you, and how do you get over it? Or how do you?
Well, I just, what she said right at the end really resonated for me. I think I talked to you about this once, how it's hard to be a little vulnerable actually sometimes and tell your personal story, especially when you are operating at the level of governmental, context, and you're presenting at UN General Assembly, and you really, I was very afraid of the emotional part of the story for a good while there, because I didn't want to be viewed just as someone who had this like, oh, look at this, these sad stories, or, just basically the slide of the cute baby, right? And the mom who advocated because something kind of scary happened, right? So I would really just lean in heavily, and I still do that to this day, but just lean in heavily to the data and the real benefits to population health approach to diagnosing and treating children earlier. But you can't be afraid of the personal story, because that really is what, well, it should empower all of us to embrace it, to to Maya's point, but it can make all the difference with a policymaker or someone who can really, if not flip a switch to make something happen, at least somebody that has the influence available to push things along for you. So that to me, I think is still a little bit of a challenge. I'm very Midwestern Minnesotan that way. I don't like to, it's just hard sometimes to talk about Eve and that personal piece. So I just would encourage people to like feel okay in your own shoes in doing that. You can't just do one without the other, but don't ignore that thing that comes from your heart.
Thank you. Anu, if you don't mind, we have a question from the audience that I want to make sure I get to. So I think we have, let's see, there's a question that says, thank you for all of your inspiring work. I'm currently working in the CHD space in Canada, representing Heart and Stroke Canada. We are hoping to create public policy around increasing access to care using a lifespan approach. In your work, have you found this theme show up, and do you have any advice on tackling this scale of issue? It's interesting, lifelong care didn't, Anu raised it a little, but certainly that's a major challenge in high-income countries, is once you have those people, how do you take care of them? So what are people's comments about the lifelong aspect of this? And who wants to comment? Anybody? I certainly, I mean, I ran the Adult Congenital Heart Association for many years. I will say that I think that the lifelong care aspect is really critical in high income countries. I can certainly contact anybody who wants to hear about that. Um, I think that oddly, low resource settings have a huge opportunity that we didn't in high income countries because I was born in 1961 with complex congenital heart disease. I was literally told I was fine, that, you know, you're blue, you turn pink, you're fine. We lost a huge population. We have very significant life limiting health problems. And when, you know, this is a big thing at Global Arch that we try to really raise awareness in the global space in terms of you guys have an opportunity to come up with a model that works because we failed. I will say that less than 20% of adults with congenital heart disease in the US are getting needed care. So huge opportunity. We can learn from you. And I encourage people to, you know, connect around that issue. I see Tende is here, which is heartbreaking because we're about to end. But what I'm going to say is I know that Anna Marie needs to go. I will note that if there are attendees who would like to stay, if any of the participants can stay longer, I certainly can. You're welcome to do that. And certainly Tende, we have already promised and made a commitment that we will hear your voice. It just is not going to be this time. And I will highlight that that's one of Global Arch's biggest challenges of doing global work is that anybody who tells you that everybody has internet or everybody has fill in the blank is wrong. Okay, at least in terms of challenges. Thank you again to Anna Marie, and I don't know who else is going to have to go now, but those were extraordinary. I also want to note that this was recorded. It will be available. And I certainly am going to look back at it. So
Thank you, Amy. It was so good to see everyone. Happy World Heart Day. I'll drop off, but please stay on. What a great conversation.
great. So I'm going to start out with a question for Tende since she's still here, which is, Tende, I want you to just tell a very specific story because I know we're not going to have time for all your slides, which is, I know you've been working with the World Health Organization, and I said to you, Tende, tell me exactly, how did you even get their attention? And you told me a funny story about a conference. So can you start there?
Okay, so the World Heart Organization had actually come down to Bulawayo for a seminar for cancer. So I heard they were traveling into our city, and I actually went to the cancer seminar. And when I went there, had to wait for them to, and then when they were done, I asked for a few minutes with them, and they asked who I was. So I actually started unpacking my story, which was very long, and they had finished at around 5 p.m. And we ended my discussion around 7 p.m. because I wouldn't let them go until they heard the plight of children living with heart disease in our nation. So they asked me to write and present my concept note, of which I did. And then they got back to us and managed to sponsor the t-shirt that I'm wearing and some of the first awareness material in our nation in Zimbabwe.
Great.
So it wasn't easy getting their attention.
Thank you. We have another question. Oh, actually, well, let me go on to the other question. I'm going to allow Filomena Anyanhu to talk. So go ahead, Filomena. And can you first tell us where you're from, your organization, and if I'm messing up your name, your name?
Okay, hello, my name is Filomena Anyanhu, as she said. I'm from Nigeria. I'm the CEO of LH Care. LH Care is an organization, an NGO that works in the rural communities. We care for the older persons, especially for the people who live in far to reach and remote areas of Nigeria. we do that. I'm also the president of an association, Association for Care Service Providers to Older Persons in Nigeria. We try to improve the quality of care to older persons. And by doing a lot of things, like through standardization, defining quality care, monitoring. Of course, a lot of care homes are springing up in Nigeria to meet the demand of older persons' care. And there are no standards to check the quality of care provided. And of course, you see a lot of abuses happen, and that is why the association is there to checkmate some of those things. So far, we have been able to create a set of standards, care quality standards, and that's the first ever in Nigeria. We don't have a monitoring body. We don't have a regulatory body in this country. Sorry, I'm in the car, so I'm just trying
That's okay. You've raised a really good issue, which is around quality standards. I'd love to pause you there and have the presenters comment on that, because that didn't come up. And I will note that particularly in heart surgery, which all of us need, and particularly with heart surgery on hearts that are the size of a walnut, quality is a huge issue. So does any of our panelists like to comment on the issue of quality? Like, how do we get quality incorporated? I also just want to note that in the US, interestingly, we do not have mechanisms to police quality because of the way our healthcare system works. So surprisingly, even in the US, health quality is a huge issue, particularly in heart disease in general, and childhood onset in particular. So Anu, you haven't spoken a whole lot. So do you want to comment about quality?
Yeah, I just wanted to share a few, one instant where one of my colleagues questioned me when soon after my second surgery, when my mitral valve was replaced, I started having palpitation, and I noticed a different feeling that when I was more ill, I didn't used to get that feeling, but when soon after my surgery, which I hoped it will help me be healthy, but still I'm having palpitations. And one of my colleagues asked me or questioned me, maybe the valve that you have inside your heart is not suitable for your, or maybe it was small or large, and it created that palpitation. And I was not able to answer because I was assuming that the surgery team or the hospital who decided the valve to be used in my heart was okay or fit for me. But at that moment, I just questioned about that. And just like what we are discussing, I think also there's also another area where we can think about what quality means for the providers and the service receivers, because as a person we might have our different understanding or definition for the quality service, and the provider's definition may be a little bit different, and there might be some gap. And I think there is an opportunity to look microscopically on that issue also.
Thank you. Maya, do you have anything to add?
Yeah, I mean, from a much more kind of broader policy perspective, I think when you start to look at the language we're using, there's a lot of people who are, advocating about access to care. But if you start paying attention, people mean different things. And I feel like equity and quality are two things that often get missed. It's so easy to talk about cost effectiveness or talk about feasibility, sustainability, like some of these things that are usually around limiting because of resource constraints, limiting the options. And we should be focusing much more on not just getting services out to places where they aren't, but making sure those are quality, and we have well-trained health professionals. People living with NCDs are part of the quality improvement process. kind of, I think it's really great to hear from Philomena, and it's been great to get to know her over the last couple of months as she's gotten involved in some of our initiatives. But that quality piece is so important, and it's often missing from even the broader advocacy conversation of it's not just enough to get care, but the standard of care needs to be as high regardless of where you live. We're selling everything short if it's like, oh, you get that and we get this. We really need to kind of fight for quality in addition to access.
Thank you. And I will note that the World Health Organization says that all of us have as our human right the highest achievable level of care. And I find that often survivors of childhood onset heart disease have been told many, many, many times, you're so lucky. I was told at age 32 or 34 when I had a 3-year-old, you're so lucky to have lived this long. And, all of us deserve to live a lot longer. We may not get a chance, and this is where we have to keep pushing. I don't see any more questions from the audience. We're a very small group now, so I'm happy to let you talk. I just want to circle back to Tendai because she wasn't able to come until late. Is there any specific thing you'd like to comment on or add at this point? Because we're going to have to leave in 4 minutes. So I know you have slides. I wish you could show them, but do you want to talk a little bit about what you've achieved? Because we'd love to hear that. And let's see if I can make sure she's not muted. There she goes. You need to unmute. Uh-oh, there she is. And if you can,
Okay, can you hear?
We can hear you. Go for it.
Okay, so basically what we have managed to achieve is that we have communicated with our Ministry of Health to actually include policies of children and people living with cardiac diseases. It's still in the process because it's still being discussed by the health portfolio, and they are making engagements in the nation. So, we are happy that those engagements have begun because all along it was quite silent regarding heart issues. And secondly, we have been engaging with UNICEF, and they have given a 3-year grant to actually evaluate childhood non-communicable diseases, including heart disease in children. So it's a great milestone from when we started in 2019, and there was no talk about, heart disease. It's not easy, but so far we've also managed to have a cardiac unit in the southern region of Zimbabwe at Mpilo Hospital, and we're hoping to actually have more of those cluster units in the 10 provinces of the nation. And we've managed to engage with Rotary in our nation, and they're willing to help us equip the hospitals and also set up infrastructure. So all of this is a work in progress. One step at a time. It's not easy because we don't have the financial muscles. We don't have funding for our day-to-day admin costs. But what we do voluntarily, and slowly but surely, there is progress. I know they won't actually give the credit to us for making all the noise because we've been high and low in media, but we are happy something is being done in our nation.
Thank you so much. I think that's a wonderful place to end. I want to thank all of our attendees. I have to say, I thought this was so superb, and I'm so inspired by each of your stories. And as I said, this will be taped. And I know that all of the panelists are happy to be in touch with you afterwards. If you want to find out their emails, just email info@Global Arch. You can go to our website and we can get you in touch. So I thank you so much. I couldn't have had a better start because here in the US, it's in the morning to my World Heart Day. So hopefully we'll see you again.